Now I want to talk about the aesthetic zone. The aesthetic zone, it's a different. Why? Here, actually, I'm showing two cases that are much more than only socket, but I consider them as a socket just because we did the extraction in this time and we did augmentation simultaneously. But actually, it's not a socket, it's much more than a socket. Here, we need to preserve the papilla. Here, it's a young guy with a high smile line. Here, we have another problem. It's a very thin type of soft tissue. And we know when we work with a thin type, every small mistake, we're going to pay for it. We're going to have resorption. Unless we grow soft tissue. We don't borrow from other place. Because if we borrow from other place, then we need to correct the papilla. Here, we don't do it. And I'm going to show what I mean by that. So we have a big defect here. We need to extract the tooth. By the way, I want to thank Dr. Baranes for many of his cases here. And I'm showing them. Some of them we did together. So here we need to extract the tooth. As you can see here, we distinguish between the keratinized and the mobile mucosa. We do our vertical cut, and by the way, only one vertical cut because we don't need a tension-free flap. We have a stretch flap. So one vertical cut, if we do, is enough. Sometimes we do it by envelope, but personally, I don't care to do one vertical cut because it's not invasive. I'm not going too up into the mobile mucosa. So by the way, you're going to see that when you do in that way, your patient will come with almost zero swelling, zero pain, because we are not going up into the mobile mucosa, especially if we give them a dexamethasone according to the protocol. So what we're doing here, 3 millimeter into the mobile, and then we start to undermine with the periostal elevator, and we clean the defect. Now, in order to preserve the papilla, we need to evaluate the defect, okay? Here we see that we have bony wall that can preserve the papilla for us, and then we can grow soft tissue here in the area. I'm going to show how we do it. So we activate the bond appetite, then we inject it into the site, buccally and occlusally, take a dry gauze press, then a periostal elevator, and now we don't close the flap. What do I mean by that? I mean, we suture in one end, in the other end, and in the middle, as you can see here. Why? Because we want to grow soft tissue in this area. We don't want to stretch and to close it because we want to preserve the papilla. But again, the material cannot be left exposed. We must protect it. So, as you remember, we take a collagen sponge or collagen plug. If you use a plug, just squeeze it. You can use as well the Oraid wherever you have it. And we secure it here when we work with the collagen sponge into the buccal aspect, palatal, and then across suturing. Remember, don't try to undermine the sponge underneath the flap. Inverse, it should be placed above. It doesn't look nice, but it's extremely efficient. And of course, we cannot use a flipper. We need to use a temporary Maryland and to bond it to the other teeth. And now, at the day of the surgery, you can see that the papilla is perfectly in place. 2 weeks later, the papilla is still perfectly in place because don't forget, we grow soft tissue. We don't borrow it from other place. Normally, of course, you don't need to take the Maryland bridge out in order to see what happened. We did it in order just to show you what happened underneath. So here already it was bridged, but still it's very, very young soft tissue. 4 weeks later, see the papilla is perfectly in place. And here already is bridged. We never get scared that it's going to be infected due to exposure. We never encounter even one case of exposure that lead to infection. Yes, it can be infected if you put it in infected sinus. It can be affected from if you put a membrane that stay a longer time and it's absorbed a lot. But exposure, never. We never had even one case of infection. That's how it looks 12 weeks post-op. You can see beautiful papilla in place and beautiful keratinized tissue that grows there, that proliferate above the exposed area. And now, of course, we need to see if we have bone. So that's the bone that we gain. You remember how it was. And everything is bone. And of course, now we can place the implant in the right position and continue with our procedure.